Okay, everyone, welcome back from break. Hope you enjoyed speaking with some of the sponsors. Our next event is going to be a case review and panel presentation with Dr. Versluys and Cole. And I want to remind everyone that the attestation form link is going to be in the chat box, and we'll continue to be asking for any questions to be posted in the chat box as well. With that, if the doctors are ready, I'll turn it over to you.
Sorry. Hello, Dr. Cole. First time we see each other in person, but we've been emailing a lot. So
yes.
Good. You will be doing the PowerPoint and sharing your screen, I see, and then I will present the first case. Go ahead, like that. Yes, next slide, please. Good. So the first case we have chosen this is one of my cases. Dr. Cole has a similar case coming up in a little bit. Female patient, about 45 years old, diagnosed with fibromyalgia, chronic fatigue syndrome, and clinical depression. From a Chinese medicine point of view, from a differential point of view, her body aches were of a migrating nature, so that's kind of has value for Chinese medicine diagnosis and herb choice. So one day pain is here, the other day pain is there, so kind of moving around. Severely fatigued and just absolutely, no energy to do anything. As a result of that, this patient would sleep 10, 12, 14 hours, you name it, just stay in bed, like definitely did not have energy or just the desire to be amongst people or do anything particularly during the day. The patient was very depressed with suicidal ideation. Obviously, these are all patients, obviously, that are managed by their respective specialists. They just came to me like after trying to get a little bit more improvement, beyond just the regular management. The patient was on a selection of medications, some over-the-counter pain medication, including one opioid pain medication. I wrote these cases up a little bit fast, so I never actually went to check the paper charts to see exactly which of those medications it were, and I apologize for that. Patient was on antidepressants as well as on anxiety medication. So that kind of was the presentation. As far as a body type, patient was definitely very obese, heavy set body type. So that was definitely another comorbidity of this patient. And possibly due to diet or possibly due to medication or a combination of the two, the patient had just a kind of general sluggish bowel movements, constipation, like fullness, distension in the abdomen, and so forth, which is one of the things that I treated. At one stage in the treatment plan, I actually had to treat that a little bit more overtly and pause the main treatment for a little while, but I did not include that kind of session in the slides here, just for brevity. I didn't want to make it too complicated. But yeah, so you definitely had to help with digestion and those kind of constipation and distension symptoms. Next slide, please. From a Chinese medicine point of view, Chinese medicine doesn't have a specialized nomenclature for naming disease names. There's a little bit, like there are some archaic disease names, but generally speaking, Chinese medicine uses the chief complaint, the primary symptom, as the diagnosis. And so, if you're suffering a lot of pain, Chinese medicine will just call that a pain pattern or a pain syndrome. Keep it quite simple. What we call deficiency taxation, that is a specialty disease name that is employed in Chinese medicine. It's a very old disease name from like 2,000 years ago in China. And it refers to just an absolute exhaustion pattern. This is something we see a lot with burnout patients, with just general absolute just loss and absence of vitality in patients, and that is then called a deficiency taxation syndrome. This patient received both acupuncture and herbal medicine, and we will talk about her results in a bit. you'll see that, especially when people are doing both, and especially after the first 1 or 2 visits, the improvements can sometimes be quite drastic, right? But that's, of course, because you come from zero and then all of a sudden you make improvement. It's kind of subjectively speaking, it feels like there's a huge jump forward. Now, the bigger challenge is to keeping the improvements coming and then ultimately stabilizing those results. But initially, the patient might report huge jumps in their improvement, right? Which is, if it was that easy, then obviously everybody would be cured in 2 weeks, which is not the case. But yes, a lot of the pain and experience of body pain in the body is treated through the meridians of the small intestine and the bladder. This is, I'm not going to go into that, why that is, but that's very, very strong pain treatment for body aches in Chinese medicine. So this patient received acupuncture treatments, and then herbally was given an herbal decoction, an herbal formulation. This is an 1800-year-old formulation. It originally conceived or designed for severe exhaustion with more muscle cramping in the abdomen. However, derivatives of this herbal prescription have been used over the centuries also for body aches and migrating pains. And so that patient was given these herbs for 1 month. And on the next slide, I can show you what these are. Very small, simple prescription. Now, if this prescription were given as a decoction, which means that, traditionally speaking, the patient would be given all these plants like roots and barks and leaves and things like that, take it home and boil it into a tea, then actually this would be the day dose. So all the tea drawn from all these herbs, you would finish that tea in 1 day. And so, but in the West, we don't use boiled herbs so much just because the sheer inconvenience, it really requires to have a live-in grandmother who has the time on her hands to boil this for you, because otherwise it's just not going to happen. So we use concentrated granular powders, which is instead of making your own coffee, it's kind of like you're doing an instant coffee idea. So you dissolve it in liquid, and so you drink it twice a day or 3 times a day. In acute cases, you can go 4 times, 5 times a day. It depends on how strong you want to do this. From experience, these cases take a longer sustained administration of treatment, and so we don't try to force too much too fast. And so this patient was given these herbs, 5 grams a day, 5 grams twice a day. Earlier, there was in my talk, there was a question about which herbs have a pain-killing effect. And if we're looking at this prescription here, then, for example, the cinnamon, it's cinnamon twig. It's not the cinnamon that we have in our diet, but the Ramulus cinnamomi, which is the cinnamon twig, is very often used in Chinese medicine for musculoskeletal pains, joint pains, pains very much of a superficial nature of the musculoskeletal system. When you're looking at, for example, the peony, the white root of the peony plant, Radix peony alba, that one is used a lot for muscle spasming and can also be used therefore for abdominal cramping and muscle spasms in the abdomen. For example, the way we diagnose this is by palpating the rectus abdominis muscle, and if it has a higher tension than it's supposed to have, that's a confirming sign for us that corroborates that we need to use this herb. So just to give you 2 examples of herbs in this prescription that have a track record of being used a lot for pain and have a good effect on pain. Next slide, please. After a week, the patient reports 50% improvement. I can guarantee you that has nothing to do with the herbs. Herbs don't tend to work that fast. I mean, it has a little bit maybe to do, in my experience, the herbs, it's about a week, 2 weeks or so, more likely 2 weeks before you really start to see the effect of the herbs. So if a patient has that much improvement that fast, it has a lot to do with the acupuncture treatment that the patient received, right? Now, the general effect with acupuncture is that you have a certain result. It's like you open a window, but somehow that window tends to close again. So after the first treatment, maybe you have some improvement for a couple of days, but then by day 4 or 5, your pain is back. So you repeat the treatment. Then maybe you have 5, 6, 7 days of good results. Pain comes back. So you kind of reiterating, like reinforcing the message to the body of what you want it to do and what you want it to achieve. And you repeat that over and over until that window starts to stay open 3 weeks, 4 weeks, 5 weeks at a time. You know, it doesn't mean they're window open doesn't mean 100% relief. Window open means some relief to a certain degree, right? What happened with this particular patient, which is unfortunately something that often happens, is that patient felt really good, stopped all the meds, and so had a major relapse. So we kind of had to kind of like, you know, have good talking and some meds she started back up, and so we had to manage that situation. But definitely digestion improvement also with the herbs, you know, bowel movements getting a little bit better. The fatigue still needed a lot of work, but at least some improvements. We then changed the prescription by modifying it by adding the herb astragalus to it. Yes. Next slide, please. The herb, the herb astragalus and the herb aconite. So the herb astragalus is actually quite well studied as a kind of a tonic herb, as a boosting herb. It's used for more than just that in traditional Chinese medicine, but it is very well known for that in modern times. And so a good hefty dose of astragalus into that formula is a standard classical modification. That's a modification that has existed for about 1800 years as well. And then the addition of the herb aconite. And aconite, obviously, it's an herb that is a highly toxic plant. You have to process it the right way. You have to grow it the right way. There's a lot of important steps that have to be taken to be able to use it safely. Need to observe dosaging and all that. But it is a very important herb for severe exhaustion, severe depression, and actually severe pain. You know, if you want to ask about, Arnaud, what's another herb that really is very strong on pain, it would really be aconite. Aconite is also known as wolf's bane and monk's hood, I think. And so very powerful, very potent herb that also treats pain. It can treat pain. It can be organ pain, like small intestine, kidney stuff. It can be joint pain, like really like deep bone pain, like bone really that feels like it's very deep in the bones. It can be migrating, moving pains through the body. It has a very wide applicability. It's an herb also used a lot for loss of sensory awareness, numbness. We use it a lot for numbness as well. So that was added to this case. But one of the core symptoms that call for the aconite is also the somnolence. And so really to bring a patient's energy back and give them more alertness, it was part of the decision-making process in adding that herb. Next slide, please. And so then basically this patient, I'm just status after 3 months now. This patient has been on herbs for this long, was continuing to receive the acupuncture on a weekly basis, at least in the very beginning, might have switched to every 2 weeks ultimately, but the patient continued to do very well. Energy was gradually improving. The patient at the end of the 3 months was no longer taking pain medication, whether that was over-the-counter medication or like prescription medication, like was no longer taking the pain medication. The patient, however, was still taking the depression medication, but was already feeling significantly better, like her quality of life had greatly improved. Now, one thing that wasn't really addressed was you know, obesity and those kinds of things like that. That would require more work, but you know, you pick your battles. And I think this patient ultimately discontinued treatments. I think finances was also a factor in that. And but yes, so this is a kind of a simplified example of how Chinese medicine would deal with a fibromyalgia kind of chronic fatigue case. Dr. Cole.
Yes. So yes. So with this case, actually, I have a similar case I'm going to present after this. So we know with various things we work with fibromyalgia patients. three things we know that work with all fibromyalgia patients are low impact aerobic exercise, reduction of stress, and maximizing sleep. So one of the things I would want to know with this patient is how was she sleeping? How much sleep was she getting? They said if she had morbid obesity, I would want to know, is she prone towards sleep apnea? Because most patients with morbid obesity have sleep apnea. So it may be worth having a sleep study to see if anything is affecting her sleep quality. And that's probably the first thing I'd want to see from a sleep perspective. Would like to see her stress level. How's she dealing with her stress? Is she internalizing that? Is that exacerbating her fibromyalgia symptoms? And then what's the depression? What's affecting that? Is there anything? Is she on an antidepressant? Is she what's causing the depression? Things like that. So I'd want to know those aspects when in treating this case. But if I was mainly want to focus on the sleep, primarily I would want to do probably like a sleep assessment, which you need to get a sleep study, and then after that, which you need a CPAP, which you also need some assistance with insomnia treatment, things like that.
For sure. I remember this patient definitely was somnolent in the sense that, she was in bed for many hours of the day,
Sure.
really had no particular, wasn't holding a job or anything like that. But on the other hand, also no quality of sleep. There was no deep sleep. There was no good quality sleep. She could be in bed 14 hours and still be as tired as before she went to bed. Like there was absolutely no impact on her her quantity of time spent in bed in correlation to how refreshed she felt. And so the CPAP I don't remember having that conversation with her, to be honest with you, on the mental health level, she was under very careful management because there had been some suicide attempts as well. And actually, when she initially had such good feeling after the initial treatments, and then she went off medication and had such a strong relapse of her pain, like was like another kind of like strong research of the suicide ideation. She didn't actually act on it, but there was for a moment there was a little bit sketchy. Like so, we had to have a good talk with her as far as like, do not change your medication.
I'm sure that made everything worse. Yeah, sure. Yeah.
Exactly.
Yeah.
And so, but over time, like after 3 months, she was off the opioids, and to my knowledge, she was not on over-the-counter meds. Even though I would personally not have a problem with it if she occasionally still had to be. I mean, the improvement was clear, and even if she occasionally had to take something, I would not be worried about that. That would be the least of our worries on that level. Yeah. But I do think that she could have used more treatments. This was one of those cases, and definitely at that point we could have maybe started addressing some other things, maybe metabolism issues as well, maybe hormonal issues. I don't know how her thyroid condition was. I mean, there might have been other things going on that weren't even focused on in the initial period of time. Would you like to present your?
Actually, we'll go through that in a second.
Or I can do mine too. I mean, doesn't matter.
Why don't you go ahead? We'll do that right now. We do yours, so that's right.
Okay. Yeah. So the second case I have prepared for us here today is diabetic peripheral neuropathy case. A male patient, 72 years old, presented with pain and numbness in both feet. Diagnosed with type 2 diabetes, which was the serum glucose was being managed with medication. So I, especially initially, I wasn't so much focusing on that. The pain and the loss of sensory awareness in the feet were the absolute standout chief complaint. Like it was impacting the patient's ability to just walk and function. Like also made him very restless with the legs. Kind of. I don't know if it would be diagnosed as a restless leg syndrome. I'm not sure what the exact diagnostic parameter for that would be, but it definitely presented to that patient as if his legs were very restless. And so patient was on Neurontin, gabapentin for neuropathy, and was not satisfied with how much he was getting from that. And so came to seek out acupuncture treatment and herbal treatment. Now, this patient I did not treat with acupuncture. I only did the herbal treatment. There might have been a period of time when this patient was receiving acupuncture from a colleague. This was a patient I saw in Portland, Oregon, when I was still working there, but I'm not 100% certain on it. In any case, if a patient were to present with peripheral neuropathy, I would absolutely recommend them to get acupuncture. I mean, acupuncture, even in the classical text dating back to 2,000 years, I mean, the texts tell you that you need to use the needles to guide the sensory awareness to the area that is now feeling numb. And so the use of acupuncture in this kind of a situation would very much be, I mean, it has to be done. So, but I'm not sure if this patient was getting acupuncture at the time. This patient was having severe insomnia. It could also be part of the fact that he was having this restlessness in the legs and discomfort in the legs. He was having some nighttime urination, undoubtedly due to I would assume due to the diabetes. And so, yeah, so he's getting about 4 or 5 hours of sleep on a good night, 5 hours maybe, not more than that. So, next slide, please. So the Chinese medicine diagnosis is consumptive thirst. That's the first diagnosis. The reason why that is the case is because a diabetic patient who is not medicated will present with thirst. And so even though nowadays you don't see that so much anymore in clinic because most people, you're on metformin or you're on actual insulin or whatnot. And so that's like the first symptom that disappears when medication is introduced. But nevertheless, the diagnosis from a Chinese medicine perspective stays the same. It's consumptive thirst. And one of the other symptoms of consumptive thirst, as mentioned in the Chinese medicine text, is indeed increased nighttime urination. And so that kind of fits. That's kind of how we end up with that type of diagnosis. Consumptive thirst is a very old disease name from Chinese medicine. It's something that's very old. The other more normal, straightforward way of diagnosing is, of course, you call it a numbness pattern or a pain pattern, or so it's very very pragmatic in the way of how Chinese medicine uses its semantics in labeling its diagnoses, right? And then, of course, his third problem was the insomnia. Now, the prescription that I gave this patient, it's called Counterflow Rescuing Decoction with Cinnamon, Dragon Bone, and Oyster Shell. So basically, it's a very long name of an herbal prescription. But Chinese medicine, that's how Chinese medicine operates. So you do your differential diagnosis, you identify which standard recipe is indicated, and these standard recipes have been around for centuries, and then you adapt that to the individual sitting in front of you, whether you add herbs or you take some herbs out and so forth. And so this particular counterflow decoction is for patients in the original text, 1800 years ago, is for patients who experience insomnia and restlessness, but at the same time can also experience severe cold of the extremities. And in Chinese medicine, severe cold of the extremities or lack of sensory awareness of the extremities can be equated. We can consider these to be a decreased circulation. As I mentioned earlier, we talked about the circulation issue, right? And so that's why this prescription was chosen, but it was a little bit modified. So I'll show you the modification in a little. Next slide, please. So the herbal prescription, again, with cinnamon, as I said, it's a very powerful herb for pain and for circulatory issues, right? The os draconis, it means dragon bone, if you read Latin. What it actually means, it is fossilized animal bone. So basically bone that was dug up, like that's fossilized, and it changes the structure of the calcium in these bones. So it's actually a type of calcium supplement, if you think about it. But it is it's fossilized, so there's something chemical that happens in there, and I'm not necessarily privy to the exact change that happens. I'm not a botanist on that level, but and then the Concha ostrea is oyster shell. and so that's another mineral supplement in a way. So this formula kind of has a lot of mineral supplementation. It's a little bit along the lines of, but not exactly the same. But as people would take some calcium, magnesium supplements, or take magnesium for sleep and or relaxation of the nervous system. So there's a comparable effect using minerals here. Much higher dose of the astragalus. So the astragalus that we used in the previous case was really just to boost the energy of the patient. The extragulus that we're using in this case is really to improve the sensory awareness of the patient. And so the modification I did here by so the original prescription would have a much lower amount of ginger, like the rhizoma zingiberries. Resens is the fresh ginger, just like we would use in the kitchen, and it normally would come at 9 grams, but the increased amount at 18 grams combined with the high dose of astragalus actually in Chinese medicine is used to have a kind of vasodilating effect on capillary blood vessels and improving blood circulation to areas that are not really receiving enough blood circulation. The original use for that was actually used more in stroke patients. Like the texts 1800 years ago tend to describe this more for patients who have had strokes and therefore maybe some ischemia that needs to be opened up. Not using an aggressive blood kind of hemolytic approach, but just kind of using a gentle, we call that a warming and opening approach. And so it's a little bit of a similar thing, but it's a very nourishing kind of approach. And then, of course, the aconite again, because the aconite, again, in the previous patient was used to build up the energy, but in this case is used to treat numbness and loss of sensory awareness. And that's also something that's literally mentioned in our classical literature. Next slide, please. And so this patient reported good improved sensory awareness in the feet. We're talking about the first month or so. The pain was starting to decrease. He obviously still was numb. He was still not numb as severely as before treatment, but he started to feel a little bit more his bottom of his feet. He was feeling a little bit more stable on his feet, and his sleep has started to get a little bit more improvement. Now, he was still getting up to pee maybe twice a night now, and I hadn't done anything on blood sugar levels, but I think just generally the improved quality of the sleep and the decrease of the pain, which was probably also interfering with his sleep, was allowing him to have deeper sleep and therefore not have to get up to the bathroom as frequently. So just a mild improvement on that level at that point. So this herbal formula was just repeated as is, unmodified for another 2 months. Next slide, please. The patient continued to improve on the herbal formula. As I said when I started the presentation, is that this patient, I prioritized the loss of sensory awareness and the pain and the sleep first. So I didn't do much otherwise on the nighttime urination, the frequency of the nighttime urination, and on the actual serum glucose kind of blood sugar issues, the diabetes issues. And so I kept this patient with that focus. And then the patient really felt like sensation was back to about 60–70% of normal, of what he remembered as normal, and pain was reduced to a manageable 2 to 3 out of 10. Again, patient remained on his medication. Like we didn't make any changes on the gabapentin or any other medication that he might have been on at the time. So we just kind of use that as the baseline, and we work hopefully upwards from the baseline, creating a certain degree of improvement beyond the baseline. Sleep was better. Average 6 hours of sleep, still getting up twice a night. And that's when I decided, okay, it's time, based on the changes that we've achieved, we're gonna chalk that up as so far so good, and now make a slight tweak, or quite a tweak, to the herbal prescription. So then I gave him what is called kidney chi pill, which is also an old formulation specifically for that consumptive thirst diagnosis. And this is a very well studied herbal prescription. As a matter of fact, it is included in Japan's national healthcare system for pretty much any man over the age of 70 will kind of automatically be given that by their primary care provider, because it's so well studied for prostate health, male hormones, for just urinary frequency, for regulating blood sugar. There's been a lot of studies done on that prescription in Japan, and so I switched him to that with a slight modification, which I mean here is tianxiong powder. I don't really know how to accurately translate tianxiong. Tianxiong is just basically another name for a specific variety of the aconite root. With aconite root, we normally use the appendages to the root. So you have a central root, and then we use the appendages that grow on the central root. Or you can use the actual central root. And so the central root in China is often sometimes called tianxiong. And so you could call that aconite powder if you want, but that would kind of not say much. And I'll show you the ingredients on the next slide. So then this patient, you see quite a different, formulation. We still have the cinnamon twig, increase the dose a bit, and it's very good for circulation improving. We still have the fossilized bone as a mineral supplement that we're still using, also at a higher dose. We've taken the oyster shell out, and we still have the aconite. So these kind of stay the same, but all the other herbs are part of that kidney qi pill that I just talked about, and that is very well documented on reducing blood sugar. Now, what happens, of course, when we do that? Now, could you say that we don't have to do that because his serum glucose is managed with medication? Perfectly fine. That, I mean, that would be perfectly fine. But on the other hand, from a Chinese medicine perspective, we try to go for we're trying to be as minimalistic as possible. So if we can help you maybe require less medication or less dosing of your whatever, if you, for example, if you're injecting your own insulin, for example, if we can reduce how much you need, we still consider that to be very valuable, right? And so that's why we would still work on that. If we can see a window of opportunity to work on that, we would do so, especially since the symptoms of nighttime urination are also covered by this formulation. And that is still something that also is reducing his quality of sleep. And so we want to continue to improve that. Next slide, please. And so then the patient took that prescription, and then so he continued to have increased sensitivity in the feet, decrease in pain. So basically, that 7 or 8 out of 10. This patient never got better than 80% from normal. I mean, there comes a point where if you've been walking around with this, no pun intended, with it for a long time, getting back to really 100% is probably not within the realm of possibilities, considering that at a certain advanced age, you also have like decreased vitality in general. And so that might not be possible to get 100%. But this patient, in coordination with his regular physician, also was able to decrease the gabapentin a bit and still maintain at a very good level of, only 1 to 2 out of 10 of pain level. And so that was actually, I think that's a good success in its own right, to be able to just take a little bit less medication. Sleep was stable at about 6 hours. I think, the patient did tweak his sleep medication a little bit, which then, I don't know if the patient would have gotten 7 hours as average while staying on the sleep meds, but 6 hours with less medication. Again, the patient was fairly happy with this. And then the nighttime urination also started to decrease. And so if the patient has a bad night's sleep, maybe getting up twice because he's awake anyway. If the patient has a good night's sleep, maybe only getting up once because the sleep was nice and deep. So that I think is part because we did that shift and started working more on the urologic symptoms. And then there was a general decrease in glucose serum and improved A1C readings. And so I never went that far with the patient as to start talking about whether they needed to reduce the diabetic medications. I just told this patient, like, you're more than happy to stay on this. I'm more than happy to keep you on this. More than welcome to stay on this, but I didn't. That patient ultimately was very happy with the result, and I didn't do any further follow-up with that. But there maybe was more to be done, but I think this was already a fairly a good case for, you know, about 3 or 4 months of work. This was already a really good result. So um, global improvement on every level, I would say. Yeah. I think that's the last slide for that. Yes, that's it. Yeah. Thank you.
Yes. So yeah, I'd like to comment on from a psychological perspective. So yeah, I found that probably people have seen with peripheral neuropathy, it's sleep is really usually horrible with these patients because fortunately they lay down at night, right? So when they lay down, that's when they feel it more, and it actually so their sleep onset is really poor. So the fact that you were able to get this gentleman to sleep, improve his sleep, that's significant. And also, you know, the poor sleep quality increases insulin resistance, so it makes sense that his A1C got better with this. So a couple things I would want to know: was this gentleman undergoing a lot of stress?
Well, other than his health stress, but I was not aware of this gentleman having life stress per se. I think always came in with his spouse. Yeah, that was never brought up. Yeah, it was not.
Okay, I got you. Yeah, and the reason I was asking is because I may have mentioned to you, you know, with autonomic nervous system, when you have a lot of stress, a lot of sympathetic activation, there is changes in blood flow to a decreased blood flow to the periphery, and so with peripheral neuropathy, that can exacerbate it. And so, if someone's under a high amount of stress or daily stress, I've seen where that actually can exacerbate the condition. Do you know what sleep medicine he was taking?
I don't. I was trying to find his chart, but
Sure.
I couldn't find the paper chart in which that was charted. So I apologize.
But again, in 6 hours, he's improved. All that's great. So yeah, it's about quality, not quantity. So it seems like you really improved his quality. So that's good. So, and yeah, I don't see a lot that I would have tried to focus on. Just maybe if there's any way to maximize sleep even more. But it sounds like that's already improved. He wasn't having a lot of stress. There was not a whole lot I would have addressed with it.
Yeah, he was a retired gentleman, so it didn't look like there was any work stress left.
Yeah.
But, you know.
Yeah. Yeah. That's very interesting.
Thank you.
Right. So, I was going to do we're going to do some sleep treatment examples for chronic pain cases, in addition. And so this first one was very similar to the first one we thought was a fibromyalgia case. So this was a 47-year-old Caucasian female. She had 10 years of chronic overall body pain and fatigue. She also, it's interesting, she had 11 years of chronic insomnia. So the insomnia precluded the overall body pain. She was presenting with inactivity, not very active, depressed mood. And her primary care doctor, knowing that sleep is important for fibromyalgia, was giving her Temazepam for sleep. That was what she came to me on. That's what she was taking. Okay, so this is the basics when we saw her. So I did a sleep assessment. So her sleep latency or her onset, it was taking her at least 2 hours to fall asleep when she lay down. When she'd go to sleep, she'd wake up at least 7 times a night that she knew of. And it would take her at least 30, on average, 30 minutes to go back to sleep. And her total sleep time was about 4 hours total. But she was in bed 8 hours, but she only slept 4 hours of that. So her sleep efficiency, which is basically the amount of time you're in bed asleep, it was only 50%. We generally want to try to get somebody's sleep efficiency to 85 to 90%. So 50% is really not great sleep efficiency. So I assessed her for, does she have any symptoms of sleep apnea, like she's snoring, gasping for air, or does she have any periodic limb movements, things like that. There was none of those. So that was negative. Naps. She was taking 2 naps each a day, falling asleep for 45 minutes each, and laying in bed quite a bit. So I was looking at her partner's sleeping habits. So it was basically, did her spouse did not disturb her. He wasn't sleeping. He wasn't snoring excessively or moving around a lot. So that wasn't influencing her amount of sleep. And her stress level was her only main stress was her symptoms. Her fatigue, her pain, her lack of functioning. That was her main. The symptoms itself were the stress. Right. So what do we do with this? So we'd want to start with CBT, iconic behavioral treatment for insomnia. So first thing, we consult with our primary. So, because remember, temazepam is a benzodiazepine. Okay, and remember, benzodiazepines block delta or deep sleep, and that's going to make her pain worse. Fibromyalgia, that's going to make that go through the roof. That's going to be one of the worst things you can give somebody for sleep, for that have particularly almost on the all pain sensitive. Fibromyalgia is especially sensitive to sleep. And so giving a benzo may allow her to go to sleep, really wasn't working, but it's going to block her delta. So first thing is talk with her primary and have her primary wean her down, because they're the one prescribing that. And then we basically see her after she's been off the meds for about a week. So when to get out of her system for about a week. So we would teach her the basics of sleep. What's, we go into the, like what we talked about with the presentation, the stages of sleep, what it takes to go to sleep, things like that. Want to also try to tell her, don't try to sleep. Remember, sleep is inhibitory. She's trying to force herself to sleep. It doesn't work. Then we want to limit the amount of time she's in bed. She's awake. So she's in bed. I think she's in bed 8 hours at night, and she's in bed about 3 or 4 hours in the day. So she's basically training herself to be awake in bed. She's actually awake more than she is asleep in bed. So she's training herself to be awake in bed. And so if she's in bed, I always tell the patients, I mentioned to you, your bed's for sleep and sex. If you're laying in bed, it's been more than 20, 25 minutes, and you're not asleep yet, get up and go read something boring in dim light. And then when you start getting tired, then go lay back down. Okay, that's one of the things we want to do for her. We want her to turn her clock around. Well, what time is it? What time is it? I don't want to know what time it is. Okay. 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 So one of the things, we also want to set her circadian rhythm. She's kind of getting up at different times and kind of when she feels like it or whatever. So we want to set her circadian rhythm by setting a standard wake time. So she wanted to make it, I asked her, what time do you want to be up in the morning, no matter what? She said 7 a.m. Okay. So I want her to get up at 7, no matter how much sleep she got. If she only got an hour sleep, she has to get up at 7 and stay up. No naps, staying up. And then the next thing we do is we have her track her sleep and look at her average amount of sleep a night. She's getting about 4 hours of sleep a night. Okay. So what you do is you go backwards from the amount her wake time to set a bedtime. Okay. So she said she wanted to get up at 7, right? And so she's only getting 4 hours a night. But I never go less than 5. So instead of 4, I want to make it 5 hours. So basically, I want her to sleep. I say, okay, so I want you to sleep from 2 to 7 a.m. only, no naps. Okay, and this is what everybody, and this patient and all my patients look at me like I'm crazy. Okay, so I tell them. So this is what this does: is this takes the pressure off you trying to sleep. You actually have to wait to sleep. It also makes you extra tired and builds adenosine in your brain. It may take 2 or 3 nights, but eventually you're going to be so tired you're going to crash. But because you're only allowing to 5 hours of sleep, you're getting more condensed sleep or quality sleep. Remember, the total amount of delta and REM is not even 4. You're going to get condensed sleep. Okay. Now, once you start sleeping from 2 to 7, pretty good. Doesn't be 100%. Let's say 89%. For 5 days, because it takes 5 days to set up your circadian rhythm. Then I want you to back it up and go to bed 30 minutes earlier. Okay. And once you're doing that well for 5 days, you back it up and you go to bed 30 minutes earlier. So increase it, keep increasing. Get up at the same time, but so 7, you always get up at 7. But so you should get up at 1:30, then you get up at 1, or sorry, go to bed at 1:30 and then go to bed at 1. So the best example, I view this kind of like physical therapy for sleep. If you break your ankle, you don't take the cast off and go running right away, right? You got to stand on it, walk on it, jog on it, then you can run on it. But you don't try to run on it as soon as you pull the cast off, right? We got to get quality sleep and then quantity sleep. Okay. So we're to keep backing up like this. And again, I always tell patients, the first week you're going to hate my gut, you're going to cuss me. Second week you're going to like me much better. So because you're going to be very tired, but I want you to be tired. You can't make yourself sleep. And what you're doing is you're setting conditions in your life that your body eventually has no choice but to sleep. Okay. Right. So I wanted to increase, I said, 30 minutes every 5 days. So what's the end game? Okay. So how much do we do it? So remember, everybody has a different optimal level of sleep. Some people need 8 hours. Some people only need 7. Some people need 6. So Like that gentleman we talked about, he may only need 6 hours. He may be a short sleeper, but that may be all he needs. So I want to start the patient at 5 hours and then keep increasing her sleep every 5 days until she's not sleeping as well. That means she's sleeping too much. And then we go back the other way and figure out what's the sweet spot. So let's say, hypothetically, let's say her sweet spot was 7 hours. So we start at 5, the closer we get to 7, the better she's going to feel. But she starts sleeping 8, 9 hours, she's not going to feel as well or sleep as well. That means she's sleeping too much. So we go back the other way, if that makes sense. So an important way to find out what's going on, we want her tracking her sleep data, sleep quality. And we will look at that, see what the best amount for her. Another thing we do is we teach her relaxation to help her lower her body temperature prior to bed. Also, the relaxation will help her with any stress management she's having during the day, which can help affect the fibromyalgia. We also address her irrational thoughts about sleep. So, like, I can only sleep with medicine. Well, people have been sleeping for thousands of years without medicine. Or she has a thought that, oh, I'll lose my job if I don't sleep. Well, okay, how long have you had sleep problems? 11 years. Well, how many times have you been called into the office to be fired? Well, none. Okay, well, okay. So, so there's no proof that this is actually impairing you. Now, it's not fun. You don't like being tired. You don't like insomnia, but it kind of takes the sting out of it. It takes the worry or the catastrophizing people do. Because when you're tired, you don't think straight. And so when you don't get a lot of sleep, and then you start thinking of all this stuff, and that the way you think is irrational, and then that just perpetuates the anxiety you have about sleep, and then that anxiety makes your body temperature go up, and then you can't sleep. So we're trying to minimize any irrational thoughts she's having toward her. Now, once she's sleeping pretty good, okay, and that's restorative factor. Once we get everything fixed at night, you can try a 1 hour nap or less. So it had to be an hour, but an hour or less nap between 11 and 4, if she can do it, if it does with her work or whatever. So a lot of people are telecommuting so they can do that. So, but I generally, you don't want someone to sleep more than an hour because that burns too much adenosine, like your sleeping fuel. So you can't sleep at night. You don't want them sleeping before or after 11 or after 4 because it throws off your clock. So our body is made to take that siesta. Not everybody does it, but it's made to take that. You can try it and see how she does. She doesn't have to, but that's an option that she can do. Okay. All right. So after 5 weeks, she went from sleeping 4 hours a night, which she settled on about 7.5 hours of sleep. She reported, again, she wasn't pain-free, but her pain went down about half. Okay. She's a lot more active, not as fatigued, and actually her depression went away. There's been some studies, I didn't report on this, but they're actually recommending if someone has insomnia and depression, treat their insomnia first because their depression may get better. And her depression actually went away. So by just treating the insomnia. So that was a condition that we saw. And she did pretty well. What we do to minimize a relapse for these patients is we tell them if you're trying to, that if you say you're not sleeping good, and one night here or there is not a big deal. But say they're not sleeping well for about 6 nights in a row. What I want them to do is for 2 nights, shock their system, only allow themselves 5 hours of sleep for 2 nights, and then go back to sleep normal. That you kind of reboot the system. Use sleep restriction like you would a sleeping pill. And so that tends to work pretty well. And then they feel more confident. They feel like they can control it. That's how they react to that. So all right. So Dr. Versluys, do you have any comments on this patient on how you would address it from a Chinese medicine perspective?
I mean, what I briefly mentioned in my morning session is that because Chinese medicine puts pain, sensory awareness, and sleep all on one organ system, we put it all on the kind of the heart-mind organ system, that it is very not foreign to a Chinese medicine practitioner to see pain improve with an improvement of a person's mental state, or pain improve with the improvement of a person's sleep, or even their just kind of body sensations improve with an improvement of their sleep or mental state. And so I think I can confirm that this is very much in line with how Chinese medicine would approach this as well. Yes.
Excellent. Okay, right. Okay. Well, I know you've already commented on your first one was very similar to this. This next one, a little bit different than what you did. So, this is a patient with lumbar pain. So it's what probably most of us see, in pain. So it's a 54-year-old male, 15-year history of lumbar pain. He's morbidly obese, like you talked about that gentleman in the past. He has obstructive sleep apnea. He's actually being prescribed 50 micrograms of fentanyl, but he's not using a CPAP. Not using it. He's been diagnosed with sleep apnea, not using it. Okay, so how do we address this? And this actually, this is interesting. This is the kind of case that got me into starting to sleep. A case very similar to this. What got me interested in starting to do, what can we do with this situation? So sleep assessment. So it's taken a little while. It's not as bad as our first one, but it's taken about 45 minutes to fall asleep. He's waking up a lot. He's waking up at least 12 times. And he's getting about 6 hours total, but he's in bed 10 hours. Okay. So his sleep efficiency is not too great. It's about 60%. So, and when he gets up, he has to go to the bathroom. Now, this is what's interesting. So, a lot of times, sleep apnea will make people go to the bathroom more if they don't treat it. They'll have more urination at night if they don't treat the sleep apnea. Now, he's not using his CPAP because it makes him anxious. Okay. He can't breathe. He feels he can't breathe when he's using it. Now, what's interesting is this is what drives me nuts here sometimes. So the patient is a mouth breather. So when he sleeps, he naturally breathes through his mouth, not his nose. You know, and they gave him a nasal mask. So what's gonna happen is when he opens his mouth, it breaks the seal, and he really can't breathe. The air will flow out, and it messes him up. Um, so that's set up. So that also probably made him feel anxious, like he couldn't breathe with it. He's also feeling fatigued during the day. He has no energy. Even though he's in bed 10 hours, he just doesn't feel good. Okay. All right. So what do we do with this gentleman? So we do CPAP tolerance and desensitization. So we teach him the basics of sleep, like I would with any insomnia patient. Also, I try to talk to him about sleep apnea. With mentioned to him that sleep apnea, that it causes, it affects your sleep quality. It's going to make your pain worse. It makes you gain weight, and it increases your risk of having a heart attack and a stroke. All these things, and that combined, and you're on 50 mics of fentanyl. That's going to really amplify that. That's going to be a double whammy, really dangerous. But also, we try to I don't try to shame him. Yeah, with all the doctors, try to give him a hard time by not using the CPAP. I say, look, it's normal. That's freaky. You're trying to put them on your face and have them blow air up your nose, and it's not, and it feels like you're suffocating. And another problem is they gave him a nasal mask, and that's not going to work. So what we do is we teach them relaxation first, teach them how to relax, have them obtain a full face mask if he's a mouth breather. Then I want him to wear the CPAP during the day and have you use his phone or a watch for secondhand. I want him to use it. If he can wear it 5 minutes, wear it 5 minutes. Okay. And then just slowly increase his time until he basically can wear it for 60 minutes, full blast, nonstop. Okay. I remember my most, I guess, CPAP phobic patient. I saw a very large um, um, police officer one time, real tough guy. The longest he could wear his CPAP, I'm not kidding you, was about 7 seconds. Okay. So what we did, we just had to set, this took a while. So with this gentleman, I just got to stop and watch out. Okay. We're at 7 seconds. Great. 7. Let's try 15 seconds. Right. Let's try 20 seconds. And we just slowly build up until he could wear it for an hour, and he uses it all night now. So just getting him tolerating, used to tolerating that pressure while he's awake. So that's the main thing. Okay. Right. So, no, I don't want to try to sleep with it. Do not try to sleep with that CPAP until you can tolerate wearing it while it's on for an hour for an entire week. Okay. Now, then after he tolerates the CPAP, we go through the CBTI. So we treat the insomnia as well. But the CBTI won't work unless we're treating the sleep apnea because he's having problems. He wouldn't achieve deep sleep with and feel well rested unless his CPAP is adjusted. So I want him to limit the amount of time in bed awake. Then he wanted to set his wake time at 8 o'clock. So I don't go to bed to 2. right? So I want 6 hours total. Well, a lot of times when I tell them, the patients with the CPAP, I want them to stay up later to make them extra tired. I say, I want to make you so tired that you don't care if there's an elephant on your head. So you're just going to fall asleep. So, but it makes it easier for them to tolerate that. Then have the patient increase sleep time 30 minutes every 5 days by going to bed 30 minutes earlier, if that makes sense. So very similar. We're adding the CBTI part with this to the CPAP tolerance part. Okay, so patient is sleeping through the night and tolerates about 6.5 hours of sleep wearing the CPAP. Here's one thing you got to think about with back pain patients or with any kind of pain patient. So which works with back pain patients, they can't be in one position too long, can't sit too long, can't stand too long, can't sleep, can't lay down too long. And so I always tell my pain patients, if I gave you a pill and it knocked you out, you slept 9 hours, you wouldn't be able to move the next day. So I want them to get enough sleep to feel rested, but not so much sleep that hurts their back. So there's that balance sometimes with back pain patients. You want to have them sleep, maximize their sleep, but not too much. So he's sleeping 6.5 hours at night wearing a CPAP, so he's getting delta sleep, taking pressure off his heart. And we have him use an hour nap wearing a CPAP after lunch. I put weaning a CPAP. I'm sorry, those don't think that. Wearing a CPAP. So, but actually, his outcome, he's more rested during the day, and he's more active. And his pain actually went down 3 points. And he still hurts, but it went down about 3 points on a 1 to 10 scale. That's one thing that we had. One last thing I want to mention real quick. I think it's important for the patient to be considered for bariatric surgery, weight loss surgery. I know some of my other specialties, but the thing is, if someone's morbidly obese, they have less than 5% chance of getting that weight off with just diet and exercise. So that's the only thing we know currently that works for morbid obesity is weight loss surgery. So I want this patient to consider either the sleeve or the bypass. If he did have bariatric surgery, we would need to have his CPAP changed to an auto mode because as he lost weight, he wouldn't need as much pressure. That would go down. So, right. So thank you. And I know we have about 4 minutes. So Dr. Versluys, do you have any comments that you want to do on that or any questions on that?
Maybe just one thing that I want to mention is that people sometimes turn to Chinese medicine for weight loss and tell them not to. It doesn't work. It has to be an integrative approach, and there is no one herb that makes you lose weight. Otherwise, I'd be a millionaire, and I probably wouldn't even.
I guess sure.
Okay, gentlemen, thank you. That was brilliant. You guys make a great team. I feel like I got a lot of options now for some of these patients who fit these categories that maybe we can do a little better than we've been doing. We're just about out of time. I think we've got about 3 minutes for questions. I do have a lot of questions. I'm gonna try to ask maybe a couple of ones that can be answered fairly quickly, and then we're moving on to our poster presentations. Dr. Versluys, so just in the examples that you gave there with some of the, you wrote off this fairly specific cocktails for the herbal regimens. Do you counsel patients with any one of those particular regimens on any side effects or anything? What do you commonly see, look for, if any?
We always have quite an elaborate talk about what to look out for. The majority of herbs are really benign. I mean, like I said, they're food grade. But then the odd herb, like you'd have, if a patient, for example, like these cases with the aconite, I do have to put my foot down as far as alcohol abuse and things like that, or alcohol use, not abuse. Abuse is, of course, never good. But even just with alcohol use, I would counsel them to not combine herbs and alcohol at the same time because it kind of changes uptake, and it might actually make you a little bit prone to Aconitin intoxication and things like that. So certain herbs require certain different discussions. The majority of herbs are very benign, and at best, maybe a little bit of digestive upset would be maybe the worst thing that most people would have, because it's kind of a foreign substance that needs to be digested. And obviously the palatability is not not good of herbs because there's no additives there shouldn't be any additives in herbal supplements, but yeah, so we always have a good talk, and I always tell patients to really be mindful and reach out immediately if they experience something that they can't play. Yeah, for sure.
Great. Well, great case presentations, guys. Thank you very much. We're going to move on.